One. So we are live. Please start.
Good evening, friends. Welcome to the Thursday evening webinar PG track series. And today we are into the 47th webinar. And it's such a great pleasure that we are today completing 1 year of our webinar series. We started our PG track program with our most respected Professor Anita Saxena, ma'am. And I still remember discussing with her, requesting her for the first topic, which my ma'am kindly agreed. And today, again, as I requested a couple of weeks back to ma'am to please take this particular topic, and she so happily agreed. And this is such a wonderful topic on acute rheumatic fever. Along with respected ma'am, we have the pleasure of having Professor Sanjay Tyagi, sir, who is a professor of excellence in GE Pant Hospital, Department of Cardiology. I have my colleagues, Dr. Sumod Kurian and Professor Girish MP, and we have many young fellows and cardiologists who have joined us here on this journey. Before we start this particular webinar, in case you have any questions, clarifications, and comments, please, we are very happy to take all of them. Type in the chat box and we'll take all these questions in the end. If you have any suggestions, any particular thing, please write to us. And lastly, on this Saturday and Sunday, we are having the 35th Annual Conference of Cardiological Society of India. It is focused for the residents and the fellows and the young physicians cardiologists. I wholeheartedly welcome you. It's all free of cost. That will be running 2 halls simultaneously. One will be the intervention cardiology program and the other one would be the clinical cardiology program. So please spare some time and join this wonderful lecture series on Saturday and Sunday. I request Dr. Tyagi sir to please give an opening remark and welcome ma'am for today's session, and then we start the lecture straight away.
Good evening, everybody. Today we have a very important lecture on acute rheumatic fever, which is being delivered by Professor Anita Saxena, who is a well-known authority in this field, and she has published a large number of articles and review articles, even the latest guidelines on acute rheumatic fever in the number of prestigious journals. She is professor and head of cardiology at prestigious All India Institute of Medical Sciences. I request Professor Anita Saxena to deliver her talk on acute rheumatic fever, past, present, and future, which would be very useful to all of us and the budding cardiologists for whom it is a very important topic. Professor Anita Saxena, please.
Thank you, Dr. Tyagi, and thank you, Mohit, for firstly asking me to deliver this talk. And I think importantly to keep this topic, because often we don't talk about acute rheumatic fever, we talk about rheumatic heart disease simply because we get one case in the exam. So all the fellows and residents are very interested in rheumatic heart disease, but acute rheumatic fever is something which is kind of out of our radar in most of the clinical practice. And the topic that you have given is past, present, and future is really apt because it is still, it was there, it is still there, and I don't know, I hope it doesn't stay with us for long, but I'm not so sure of it, as I will show you with the data. So I'm going to talk on the introduction, then I'll talk a little bit about the diagnosis, because that's an often asked question about what Jones criteria changes have happened in the last updated criteria published in 2015. Then, despite those Jones criteria, what are the challenges that we face in diagnosis as well as in treatment, especially in countries like ours where rheumatic fever, rheumatic heart disease continues to be there, and how can we prevent and try and control this particular disease? So I think we all know that acute rheumatic fever results from some sort of an autoimmune response to infection with group A Streptococcus of typically some strains. It involves several parts of our body, including brain, including abdomen, including joints, skin. However, everything is reversible except the effect on the heart. And then it causes a permanent damage to the heart valves and leads on to so-called chronic rheumatic heart disease. So that's how it comes into the purview of cardiologists. Burden of rheumatic fever. I think most of the developed countries and high-income countries have seen a very good decline in rheumatic fever and thereby in rheumatic heart disease. But in many low and middle-income countries, we still see lots and lots of rheumatic fever, especially if you are looking at children below the age of 15 or 18 years of age. Some of the high-income countries like Australia and New Zealand have specific indigenous populations where still rheumatic fever is quite often seen. In fact, in some racial population of New Zealand called Maoris, the incidence of rheumatic fever is actually highest. It's in the tune of, something like 100 to 200 per 100,000 population. And therefore, rheumatic heart disease becomes the most frequent heart disease under 25 years of age. In fact, rheumatic heart disease is the commonest cause of heart failure in under 40 years of age. And it is estimated, according to the data published in 2017, that over 417,000 cases are added of rheumatic fever are added or occurring every year. Most of them, majority of them, are in the age group of 5 to 14 years. And if we look at the mortality, then about 320,000 patients die from rheumatic fever, and most of them will be chronic rheumatic heart disease because of advanced valvular lesions in 1 year. And I'm sure all of us have seen acute episode of rheumatic carditis in some children, and despite doing everything that you can, these children may even die. So it is still a cause of death in childhood, rarely though. So this is a decline that you can see. The incidence of rheumatic fever has gone down dramatically. Not only that, the mortality has also gone down, and you can see the decline has started even before the discovery of penicillin. So although we say penicillin is very, very important, and I would still emphasize that later, but the declines have actually started before penicillin, but you can see the decline is so much more rapid after penicillin has come into existence. So what are the phases of rheumatic fever? First, we have a sore throat, which is usually not treated, and that is how some of these cases go on to develop so-called rheumatic fever with joint pains and swelling. And even if we treat at this stage, we can still prevent damage to the heart. Otherwise, it goes on to develop, it has carditis, and the carditis goes on to develop damage to the heart valves, producing rheumatic heart disease. Why does it happen? I think the simple answer is we don't know, but there is an interplay of agent, host, and environment. As we know, overcrowding, poverty, and all other environmental risk factors. Then there has to be an agent, that is Group A Streptococcal infection causing pharyngitis most often, although rarely rheumatic fever can occur secondary to Group A Strep skin infection. And there has to be a host which is susceptible. So not everybody with pharyngitis goes on to develop rheumatic fever, but there has to be a susceptible host, and that produces some sort of an immune response, either by immune mimicry, and produces rheumatic fever. And if there are frequent episodes of rheumatic fever in this susceptible host, that leads on to rheumatic heart disease. Why does this kind of a response happens in some of them? We don't know. These are the various theories that have been talked about: molecular mimicry, genetically determined host factors, and so on. But I think what we know is that for someone to have rheumatic fever, it has to have an interplay of all three factors: agent, host, environment, the so-called epidemiologic triad. So I would just show you one case. It's a very young girl, 6-year-old, presenting with recent onset severe breathlessness on exertion just in the last 2 weeks. She did give history of fever and joint pains, which happened about 6 weeks ago. And when you examine, she is in heart failure. She has severe mitral regurgitation, a murmur suggestive of severe mitral regurgitation. I think the diagnosis is pretty obvious in this case. It has to be severe MR. And in all probability, because there is a recent history of joint pains and she's deteriorated only in the last couple of weeks, she probably has severe amount of carditis, which is leading on to rheumatic fever. So what we are going to talk about is that how do we investigate such patients? What is the role of echocardiography in patients of acute rheumatic fever, and how do we manage such cases? So what are the risk factors? Age, we know whenever we are talking about rheumatic fever, that we say it is more common in the age group of 5 to 15 years. We also know it is very less common under 3 years of age, although cases have been reported at 3 and 4, and it's pretty uncommon beyond 30 years of age. And this is important to remember, because when we are giving secondary prophylaxis, this factor becomes important. Surprisingly, rheumatic fever is equally seen in boys and girls, although rheumatic heart disease is more common in girls. We know the risk factors like overcrowding, poor hygiene, poor housing, poverty, lack of awareness, rural location, also reduced access to healthcare. And there is some data occasionally which brings in the role of undernutrition. And as I discussed, there is perhaps some genetic susceptibility, although no no gene have been identified to be associated with rheumatic fever, but there have been some studies on HLA antigen where some specific HLAs have been blamed to cause rheumatic fever. So all in all, rheumatic fever is a classical disease of social injustice seen in poor people, people who are illiterate, not aware of the disease, do not have access to healthcare, and so on. Also, something peculiar that we see in India and some of the other countries, some of the African countries like Ethiopia is that not only we develop very severe rheumatic carditis, we also see a rapid progression of disease in India, so-called malignant course of the disease, something that you don't see in Western countries. So the initial rheumatic fever may happen at 10 years, 15 years. We tend to see them at 5 years and 6 years. Also, we see patients with severe valvular lesions in 20s and early 30s, whereas that is quite unusual in Western countries where the usual severe valvular lesion patients present in 40s and 50s. So let's come to the diagnosis of acute rheumatic fever. I think we all know, we have all heard about Jones criteria. In fact, there is no specific diagnostic test for confirming acute rheumatic fever. It is a purely clinical diagnosis where combination of signs, symptoms, and lab tests are used together to make a diagnosis. And starting from 1944, when Dr. Duckett Jones started these criteria, where you can see major criteria to begin with, they've been modified a number of times. The last was in 2003. Till then, the echocardiography was not included. But the latest update happened in 2015, published in 2015 circulation, where for the first time they have incorporated the role of echocardiography in diagnosis of acute rheumatic fever with carditis. The criteria are also introduced to have, different criteria have been introduced for the different kind of population. One is a low risk population and other is moderate and high risk population. And the authors have defined what do they mean by low and moderate high risk population. But the criteria tend to be a little different for these two populations. Of the major criteria, arthritis and carditis are the commonest or the most frequent ones. Generally, we see more carditis in younger individuals and more arthritis in older children, adults. Chorea we know is less common, and the other skin manifestations, erythema marginatum, subclinical nodules are even rarer. So this is the 2015 criteria of acute diagnosis of acute rheumatic fever, where for the first time they have included echocardiography. Also, you will see that there is criteria for initial, the first episode, and then there is criteria for recurrence of acute rheumatic fever as shown here. So in the major criteria, in the carditis heading, they've also included so-called subclinical carditis, which is diagnosed by echocardiography. The other change is polyarthralgia, which was a minor criteria before this, has become a major criteria, especially for moderate and high risk population. And monoarthritis has also been included in the major criteria as a joint involvement. Others, chorea, erythema marginatum, subcutaneous nodules remain the same. Monoarthralgia, which was not there in the earlier criteria, has also been put in as minor criteria only in the moderate and high risk population, not in the low risk population. And this has to be combined with the evidence of preceding Group A Streptococcal infection. And how do we get that? That is a lab diagnosis where you either show a positive throat culture or you show high anti-streptococcal antibody test, which is usually the ASO that we often use, but one can use anti-DNase or a combination of several antibody tests called anti-streptozyme test. Sometimes a single titer of ASO may not be very useful, or it may be still low, and you may wonder whether patient has rheumatic fever or not. It would be good to do another titer maybe in about a week's time to see the rising trend. Rising trend are very, very specific. Generally, we take a cutoff of 250 for adults and 333 units for children. But this is again based on a very small number of patients with Group A Streptococcal infection. And generally, people believe that you have to have your own region's data, whether what is the normal and what is the cutoff in, let us say, in north part of India may not be the cutoff in the southern part of India. But this is conventionally is the figure that we use. Now, coming to the major criteria, the most important for us as cardiologists is acute rheumatic carditis. The frequency of carditis, as you can see in various figures, has varied from almost 40% to even 30% to even 90%. But on an average, if you're asked this question, it is best to say 50 to 70% of patients with acute rheumatic fever will develop carditis. What is important is that those who have to develop carditis usually will develop in the first couple of weeks, first 2 weeks of onset of rheumatic fever. So if somebody has not developed carditis beyond 2 or 3 weeks of rheumatic fever, it is not likely that carditis will develop in this particular case. Conventionally, rheumatic carditis is a diagnosis of clinical auscultation. So one tends to get murmurs. All patients with rheumatic carditis should have murmur of mitral regurg or sometimes even aortic regurgitation murmur. This is a rather rare murmur, Carey-Coombs murmur, which is a diastolic murmur because of inflammation or swelling of the mitral valve. But the commonest is the mitral regurgitation murmur. We call it a pancarditis because there is valvulitis, there may be pericarditis, but whether there is myocarditis or not is something that one is always wondered, because majority of these patients will have normal left ventricular function. So despite being in heart failure, despite having severe mitral regurgitation, they have a normal left ventricular function most often. So it is not like a dilated cardiomyopathy picture, but yes, they do have cardiomegaly. And sometimes you may have cardiomegaly out of proportion to the severity of mitral regurgitation. Then you say maybe there is an element of myocarditis. Unexplained heart failure, third heart sound, not uncommon. Pericarditis, if present, will give you pericardial rub or even small amount of pericardial effusion, but clinical pericardial rub is not so common. Clinically, you make a diagnosis by the murmurs only. What we need to remember is that pericarditis and heart failure never occur in the absence of valve lesions. So if you have someone having a pericardial rub or having congestive heart failure, but without murmur, we should never make a diagnosis of rheumatic carditis. The murmur of MR or AR has to be there for making a diagnosis of rheumatic carditis. Echocardiography in rheumatic carditis can have several features. The most important one would be a mitral regurgitation, simply because there is valvulitis, we know that. But then there are certain other features that have been described specific to carditis or acute carditis. And one of them is small nodules that you may find on the mitral valve, sometimes even on aortic valve. These are small, multiple nodules seen on leaflets of the mitral valve, and they do not show a bizarre motion, unlike infective endocarditis. So you can actually differentiate it from vegetation because these are smaller, these are multiple, they are not bizarre in movement. Rarely you can have tip, I wouldn't say rarely, but often you can have tip of the mitral leaflet prolapsing, but the whole mitral leaflet may also sometimes prolapse. But this is more common a phenomena that one of the chordae may be lengthened and that produces a tip prolapse. And a small amount of pericardial effusion is not uncommon. If you look for it on echocardiography, patient may not have any rub, patient may not have any feature of pericarditis, but small amount of effusion, if present on echocardiography, along with these features, tends to indicate that this patient may be having active rheumatic carditis. What is the mechanism of mitral regurgitation in patients of acute rheumatic carditis? The commonest causes are dilatation of the annulus and elongation of chordae. So this is something we don't appreciate very well. Chordae may not rupture, but they tend to elongate, and that itself produces some kind of a prolapse of mitral valve. So anterior leaflet prolapse is more common. Rarely it may be such a severe carditis that one gets a flail anterior mitral leaflet, and this is because of the rupture of the chordae tendineae. Then the subclinical carditis, which has been added to the Jones criteria in 2015, is something that you cannot diagnose at the bedside, and that is a diagnosis made by echocardiography only. So all patients of rheumatic fever, suspected rheumatic fever, you should do an echocardiography and see whether there is some amount of mitral regurgitation or aortic regurgitation present, which may not be clinically audible. Like this patient has only mitral regurgitation of mild type, has some thickening of the mitral leaflets, seen in both the views. However, it is unlikely that you will be able to auscultate because it just looks more like mild. So people have argued that why can't it be normal, trivial mitral regurgitation that we often see in healthy people? So there are some criteria which will differentiate pathological mitral regurgitation from physiological mitral regurgitation. And these again have been given by WHO earlier and have been again talked about in this particular article that is talking about the updated Jones criteria. But what is important is that they should have a color jet length of more than 2 centimeters. Jet should be seen at least in two planes with peak velocity of 3 meters per second or more. And at least one signal should be hollow systolic or hollow diastolic, depending upon it is MR or AR. So this would differentiate physiological from pathological mitral regurgitation. The other ways to diagnose rheumatic carditis, especially if the clinical and the lab criteria are not very fitting well, people have done endomyocardial biopsy, but as I said, that involvement of the myocardium is unlikely, and therefore the sensitivity seems to be very low. Yes, specificity is good, but I think again, nobody really goes on to the extent of doing endomyocardial biopsy now. Radionuclide imaging has also been done in the past to see whether there is myocarditis or not. Again, the results have been pretty variable. And people have even looked at cardiac troponin levels. And surprisingly, despite patient being in heart failure, these troponin levels are normal or minimally elevated. I think all this points out to the fact that in rheumatic carditis, the myocyte damage or myocarditis is not a prominent feature. And therefore, it is the valvulitis, it is the valvular involvement, which is really making them sick and not myocarditis. What is the natural history of rheumatic carditis? The severer is the carditis, more likelihood of severe chronic rheumatic heart disease. So mild carditis is likely to resolve much more than severe carditis. And this is a publication from Dr. Karthikeyan in 2012, which has looked at several studies. And this is the figure they've come to, that as you can see that between no carditis, mild carditis, severe carditis, the likelihood of developing rheumatic heart disease keeps on increasing. So severity of initial carditis and recurrences of acute rheumatic fever are very, very important prognostic markers for development of chronic rheumatic heart disease. The other major manifestation we know is polyarthritis, which is actually the most common major manifestation seen in 75-80% of individuals. Typically, joint pains have been described as migratory joint pains, very, very typical for rheumatic fever. However, you may not get that always, but there could be multiple joint involvement. Most often it will be the knee and the ankle or the lower limb joints involved, but rarely you can have small joints involvement also. Spine is the least common involved. Tenderness and pain tend to be out of proportion to the redness and swelling, so much so that patients are just not able to walk. There is so much pain. When you examine them, yes, there is some swelling, some redness, some increased temperature, but that looks much less compared to the kind of pain that patient is having. It is almost diagnostic that if you give them salicylate, they would immediately improve. They will have such a prompt relief that children who were not able to walk start walking with salicylate. Not that we should use it as a diagnostic test, but if they're used and patient improves dramatically, then that is pretty diagnostic or typical. Again, as I said, it is a reversible thing, and arthritis will heal without anatomical deformities or functional abnormalities of the joint. Chorea is relatively rare, the major manifestation, but it is a late or a delayed manifestation. It happens long after streptococcal infection of maybe several months, and often occurs as an isolated manifestation. It is much more common in prepubertal females compared to males. It is characterized by involuntary and purposeless but conscious movements of the skeletal muscle, and often associated with muscular weakness, hypotonia, and also emotional instability. It may again last several months despite the treatment, but it tends to go away. Sometimes it may take about 6 months for the chorea to go away, but usually or ultimately it goes away. Skin manifestations are rarer. For example, subcutaneous nodules, as you can see in this slide, they are usually over the extensor surfaces of the joints and bony prominences. Again, one has to actually examine for them. If you don't examine all the extensor surfaces, then you are not ever going to see these nodules because they're not so big. They're small. They're absolutely painless. They're firm. They're freely movable under the skin. And most of the patients will not bring this to your attention. So you have to actually look for it in the examination. If you find them, they're very important because they're invariably associated with severe carditis. So they're like a surrogate marker of underlying carditis. So if they're present, they're very, very helpful. Erythema marginatum, we hardly see. I think I would have probably seen 2 cases till now, simply because it is less common. And also, I think in dark-skinned people, it may be difficult to appreciate. It is seen again as a non-pruritic, painless macular rash over the trunk, has a serpiginous margin, characteristically goes away. Sometimes it is there in the morning and it is not there in the evening. So it may just disappear within few hours, and it tends to become more apparent with the application of heat. There are some more features which are not included in Jones criteria. For example, epistaxis. I think we do see children of acute rheumatic carditis presenting with epistaxis. Similarly, abdominal pain may be something that may precede the major manifestation. Rarely rheumatic pneumonia. And then there are others like anorexia, listlessness, fatigue, anemia, weight loss, etc., which are probably related to systemic inflammation that rheumatic fever causes and could be related with the severity of carditis. So what are the challenges? We have these updated Jones criteria and the guidelines, but they should not ever substitute physicians' experience and common sense. So in countries like ours, where rheumatic fever is still prevalent, we need to move away from the established guidelines and look for the diagnosis, even if they are not well fitting into Jones criteria. And also there could be joint pain for several other reasons. So there could be polyarthralgia, which may not be because of rheumatic fever. So you have to keep that in mind also. Also, diagnosis of recurrences can also be challenging. But yes, recurrences must be suspected in somebody who shows worsening of the previously relatively stable valvular lesions. Rub is always acute carditis, and therefore it has to be taken as a recurrence. If there is an unexplained recent onset heart failure, and of course associated with high titer of the anti-streptococcus antibody. So this is the study that we have published, I think 2020, where you will see that in our own study of 126 children of 5 to 15 years of age with acute rheumatic carditis, the commonest feature was recent worsening of the NYHA class or recent worsening of the dyspnea. And we concluded that the Jones criteria are often not satisfied by patients being treated for carditis. Recent unexplained worsening of dyspnea, younger age at presentation, significant mitral regurgitation, presence of nodules on echocardiography, and elevated CRP are important indicators in a given case. And this we actually looked at more systematically in another paper, which is under publication, where we derived an evidence-based scoring system to diagnose acute rheumatic fever with carditis in children. And here you will see that we've given numbers to all these important parameters that I discussed, to the age, to NYHA class, to mitral regurgitation severity, mitral nodules on echocardiography, ESR and ASO. And this is the weightage that we have given with the maximum of 13. And when we plotted this curve, ROC curve, and you can see that a score of 5 was associated with sensitivity of 76% and specificity of 79%. So using this score, which we have validated in other children also, seems like a good idea, if some of the criteria of Jones are not being satisfied in our setup. So how do we manage acute rheumatic fever? I think first thing we need to remember is the treatment is totally symptomatic and it does not alter the course of the disease. So the principles of treatment are eradicating the infection with antibiotic. The commonest use antibiotic is penicillin. Symptomatic treatment of clinical manifestations, treatment of heart failure if it is present, bed rest, limitation of activity, which needs to be individualized in a given case. Secondary prophylaxis, very, very important to prevent the recurrences of rheumatic fever. In a very rare case, when there is intractable heart failure, one may have to think about doing valve surgery during the acute phase itself. So bed rest is something that used to be very strict. Many years ago, we would say, no, the child should not get up, child should be lying down, food should be provided, on the bed and all that. However, I think over a period of time, we don't believe that strict bed rest is necessary. Patients who are in congestive heart failure should be advised rest. Like we will tell them not to send them to school over the first 3 or 4 weeks and then gradually allow activities initially supervised. But even during these first 2 to 3 weeks, they are allowed to go to the toilet, they are allowed to walk in within the house, but not go out and play. Anti-inflammatory agents we know are the cornerstone for rheumatic carditis, and they also show a very prompt effect on the symptoms. Salicylates are used in those patients who have mild or no carditis, that means just rheumatic fever, whereas those who have severe or moderate carditis, especially those who are presenting with heart failure and pericarditis, corticosteroids are used. Some people like to overlap corticosteroid tapering with salicylates after a couple of weeks of corticosteroids, but we don't usually do that. We would just gradually taper corticosteroids and stop without adding salicylates at that time. And of course, we have to continue with supportive measures like diuretics, ACE inhibitors, etc. In patients with acute mitral regurgitation, often because of prolapse of the mitral valve because of carditis, we have found sodium nitroprusside infusion intravenously to be very useful in these patients to stabilize them, because otherwise these patients would need to be sent for surgery because they're quite sick, and therefore nitroglycerin, dobutamine doesn't help them much. But sodium nitroprusside seems to be helpful. Of course, one has to be careful in monitoring their blood pressure once the patient is on sodium nitroprusside, when we like to put an arterial line in all these people who are on sodium nitroprusside. Another drug that has been used quite a number of years ago but hasn't gained much prominence is the intravenous immunoglobulins. And this is one study done from New Zealand where they used IVIG and used it in patients with acute carditis. But compared to placebo, no benefit has been shown at 1 year. However, none of these patients actually received corticosteroids. So we don't have data where corticosteroid plus IVIG has been used to see whether the residual cardiac involvement will be less if IVIG is given. So I think this is something that we probably need to still study more before totally saying that it is no good. So this is just a summary of the treatment that I talked about. Severe carditis, we usually give prednisolone 2 milligram per kilogram per day with a max of 80 mg. We like to give in 2 divided doses in children, but one can use once a day also. And give full dose over 2 or 3 weeks and then start tapering, giving a total duration of steroids for about 12 weeks. In moderate carditis, the choice could be prednisolone or aspirin, but whenever we are using aspirin, especially in moderate carditis, one has to be very careful to look for any worsening. The moment there is any worsening, one should quickly switch over to steroids, prednisolone, and use the same regime as for severe carditis. Mild carditis, we don't see many of these patients because they are probably seen by pediatricians mostly, but if they come, especially those with joint pains, it is best to give them aspirin. And as you can see, the aspirin dose is not as high as we used to talk about. It's more like 100 milligram per kilogram per day divided into 4 doses. With all these, we like to use things like ranitidine or PPI. Polyarthritis, the treatment is classically aspirin, but one can use naproxen, and the dose is same as you use for myocarditis. Chorea, which is quite a chronic disease, there are several drugs that one can use, but usually it will not go away so dramatically like these manifestations. It takes it to its own time, maybe several months, and during that time, patient definitely is unable to even write properly with a pen, and therefore going to school becomes quite a problem. Valve surgery during active rheumatic carditis, we would say no, don't go for it. Only do it if there is intractable heart failure. Like this, you have a totally flail anterior mitral leaflet. As you can see here, no amount of medical stabilization is going to help this child, and therefore this is a patient who should go for valve surgery. Yes, there are certain caveats. This is a study done from South Africa a long time ago, and since then a lot of studies have come up where people have certain surgery during active carditis, but one needs to remember, firstly, it should not be done as far as possible, but in fulminant cases, one has to go ahead and do it. The repair results are not so good. So most of the patients end up having a valve replacement. Like in this case, all the patients underwent a valve replacement and not repair, because results of repair are not so good, durability is not good, and many of these patients are left with significant residual regurgitation requiring a replacement soon. In their series, mortality was nil, but then there have been several studies where mortality has been a little higher than elective surgery. But most or all of these patients had rapid deference of activity and rapid reduction in left ventricular internal dimension. This again proves that it is not the myocarditis which is causing all these problems. It is the valve involvement and the hemodynamics because of acute valve regurgitation which is producing such sick state of affairs in these patients, and therefore surgery will help. So overall, I would say surgery is feasible, although it should be avoided as much as possible. Better results are with valve replacement. One should not attempt valve repair because the likelihood of failure of valve repair is more. Surgery leads to quick effervescence, and of course, surgery mortality is high, much higher than what it would be for an elective surgery. So surgery should be considered in life-threatening cases, not responding adequate to medical management. Now coming to the last part of my talk, prevention and control. I think you've all very, very familiar this primordial, primary, secondary prevention and tertiary prevention. I think very classically shown for rheumatic fever and rheumatic heart disease. We don't have any vaccine, so primordial prevention looks like quite difficult as of now, but one can think about, avoiding overcrowding, having better hygiene, making them more aware about streptococcal sore throat. The teachers and the parents should know that streptococcal sore throat should not be ignored. But once a patient gets streptococcal sore throat, then it becomes primary prevention. And the idea is to treat sore throat so that you prevent rheumatic fever. So we like to treat them with antibiotics. Oral penicillin would be the choice. I will show you, the recommendations, and it needs to be given for 10 days. Somebody who has developed ARF already, to prevent another episode of ARF from developing, we do what is called secondary prevention, where you give them regular delivery of benzathine penicillin, which is a long-acting penicillin. And this secondary prophylaxis will prevent the occurrences of streptococcal infection, will reduce severity of RHD by preventing recurrence of rheumatic fever, and of course help prevent death from RHD. The last one is tertiary prevention, which is basically preventing complications of rheumatic heart disease, whether it is heart failure, arrhythmia, stroke, and this is done by valve replacement, by balloon valvuloplasty, and so on. But what needs to be remembered is that this is too late. Whatever we do, our results are not going to be optimal, and therefore one has to try and work more around here, primary and secondary prevention. So about primary prevention, we need to know which is a streptococcal sore throat and which is not a streptococcal sore throat. So awareness programs in school, communities, one needs to make people understand that sore throat can be a very serious problem, although it looks very mild, because some of these children may go on to develop heart disease, training of frontline health workers, clinical recognition of streptococcal pharyngitis, and ensuring free supply of antibiotic. It should be penicillin, but if penicillin is not available, one can go ahead and give amoxicillin. Some people have argued that a sledgehammer approach, where you treat all sore throats, whether they are viral or bacterial, with antibiotic may be a good idea, but then I think most believe that it is not advisable because it is going to result in antibiotic resistance. So this is how we did some work on awareness programs. So we designed some pamphlets, etc., for the Ministry of Health, and these are put in the primary health center, these are put in the school, that how do you know that this patient may be having a streptococcal sore throat. So having sore throat with fever, but no coryza, no running nose, because we know that coryza or rhinitis is often viral, and of course presence of any joint pain with or without fever. However, there are a lot of challenges to primary prevention. Firstly, 1/3 to 60% of cases subsequently diagnosed as rheumatic fever may not remember or may not recall a previous episode of sore throat. Also, viral sore throat is much more common than bacterial. Therefore, giving antibiotic to all sore throat will be overtreating. And therefore, one needs to see whether we can differentiate bacterial from viral sore throat. The best way to go about it is to do throat culture, but we know throat culture is hardly available in big hospitals, not available at a district and rural level. And also, even if it is available, it is going to take 3 or 4 days for it to show streptococcal infection. And many of these patients, rheumatic heart disease patients, never give even a history of rheumatic fever in the past. So how do you get them how do you apply primary prevention for them? So it may sound theoretically feasible, but is practically impossible to achieve at a community level. The best way is to differentiate bacterial and viral sore throat by clinical decision rule, because we know throat culture is difficult. And this is a table which is taken from 1998 article, where they given score to reduce unnecessary antibiotic use. So this is a scoring system to see whether it is bacterial pharyngitis or not. So as you can see, points have been given for high fever, absence of cough, tender anterior cervical adenopathy, tonsillar swelling, age group of 1. If the age is more than 45, then you actually reduce one number. And with this scoring, they found that if the total score is 0 or 1, the likelihood of strep pharyngitis is quite low, and therefore these children or these patients don't even require any further antibiotic, not even further investigation. If the score is 2 or 3, then the likelihood is that they may be positive for streptococcal, they may not be positive. So again, culture all of them. But if the score is 4, which means high fever, no cough, tonsillar swelling, age between 3 and 14 years, then the likelihood of streptococcal sore throat is quite high, and it is best to treat all of them with antibiotic on the clinical ground alone. Of course, remembering that throat culture is the gold standard. All this data is derived by comparing with throat culture, but a score of 4 or more would mean that antibiotics should be given. Which antibiotics for sore throat? Again, penicillin is the best antibiotic because no resistance has been shown till now to penicillin. Oral penicillin would be best. Injectable penicillin would be important because just one injection of penicillin will take care of the infection, whereas oral penicillin needs to be taken for 10 days. And many of these patients, once they get better, will stop penicillin after 4 or 5 days. So this is a good idea which has been used in many clinics in South Africa, that single shot of benzathine penicillin for suspected bacterial sore throat. We unfortunately have problem about oral penicillin availability, so we sometimes go on to amoxicillin, considering that again one should emphasize that it needs to be given for 10 days. There are certain other drugs that you can use, and those who are allergic to penicillin, erythromycin can also be used. I think what is important is the sulfonamides or tetracycline as of now are not recommended for the treatment of strep sore throat. And one should also avoid using drugs, very advanced drugs like azithromycin, because we know that if there is resistance to azithromycin, then a lot of other illnesses which are sensitive to azithromycin today one will not be able to use azithromycin. So better not to avoid very advanced antibiotic for streptococcal sore throat. Secondary prophylaxis is the most cost-effective option. Again, here we mostly use long-acting penicillin. It is believed that cost of efficient secondary prevention program accounted for only 13% of total budget allocation to ARF in New Zealand. So this is the most cost-effective option for prevention of rheumatic heart disease. Secondary prophylaxis also tends to reduce the severity of RHD. In fact, in this study, where secondary prophylaxis was associated with the regression of RHD by 50 to 70% if patients were adherent over a decade. So it is important to not only give secondary prophylaxis, it is also important to make sure that they adhere to secondary prophylaxis. And again, we often use 3 weekly injection, whereas you will read in books from the Western countries that they would use 4 weekly. But since 3 weekly injection gives the concentration, after 3 weeks, the concentration goes down below the minimum inhibitory concentration required. So we tend to believe that a 3 weekly injection should be given. And in this study, again, you can see the recurrences were less in a 3 weekly compared to 4 weekly injections. Again, there are a lot of challenges. I think we all know that penicillin availability is quite an issue. In fact, oral penicillin is not even available. There could be substandard quality. Some of the states, some of the regions ban injection penicillin in private setup. These injections can only be given in government setup. It is a painful injection. It is not a water-soluble injection powder, and therefore there's a lot of pain while the injection is being given. It is given with a thick bore needle, 21G. Very little support from industry because they don't find it commercially very viable to produce penicillin. And on top of that, everybody is so worried about allergic reaction. So a lot of these centers will not give injection, and patient has to walk a number of kilometers or patient has to go for miles to get an injection, and that becomes very difficult every 3 weekly. So coming to the allergic reactions, I think, is it a myth or is it reality? So prevalence of true penicillin allergy is actually not known, but what we know is that life-threatening anaphylaxis is extremely, extremely rare, as you can see here. Also, anaphylaxis is extremely uncommon in children. There is a recent data, I think about a year old, where they showed that anaphylaxis was not to penicillin, or reaction was not so much to penicillin, but to the other constituents of penicillin. So patients with a negative skin test that we often do to penicillin may still be at risk of reacting to full dose. So skin test may give you a false sense of security, but whenever injection is being given, it is better to be ready with all the drugs and everything, so that in case there is a reaction, one can start the management in terms of ABIL, in terms of adrenaline injections and all that. Misdiagnosis of penicillin allergy. If you make somebody say that patient is allergic, it may result in unnecessary use of more expensive and less effective antibiotics and emergence of multi-drug resistant organisms. So our practice is that if somebody comes with a diagnosis of penicillin allergy, we look at the details, and if it was a minor allergy like a rash or something, we would put them in the ward, we'll admit them for a short time, we will give skin test under observation, and if patient is fine, we give a full dose, and then we observe the patient for maybe 2 or 3 hours. If the patient is fine, then we say, okay, this patient is not allergic to penicillin, and therefore he can receive 3 weekly injections. Adherence to penicillin is best improved by having a registry-based tracking system where you can actually call the patient, or the primary health center may actually call the family and ask them to bring the child or bring the patient for injection, because many of these patients tend to forget when is their injection due. And more importantly, I think this is very, very important in case of younger patients, children, young adolescents, that we have some measures to reduce pain of injection. And there are various ways, as you see here, including use of lidocaine hydrochloride as a diluent with the BPG powder to reduce the infection, to reduce the pain of injection. Unfortunately, most clinics will not follow any of these measures, and therefore since it is a painful injection, so the patients just don't want to come and get an injection. In our own registry that we had published 4 years ago, you can see that because of the registry, we could achieve a very high adherence rate of almost 94%. And the reasons for poor adherence are primarily because of lack of awareness about the importance and the fear. As you can see, that others were not so important. In some cases, once the patient had a valvular intention, some of the physicians just stopped. They said there is no need to have it because patient has had an MVR or patient has had a balloon valvotomy. So I think we as physicians also need to be very, very aware of the fact that even if patient has had some surgery or something, the injection has to continue because there could be other valves which may get affected. So we use this for our registry. As you can see, we give this to the patient. So patient has to, every time he goes for injection, there has to be a signature, there has to be time. And when they come back after 1 year or 1.5 years, then we are able to sort of make out how well they've been adhering to injections of penicillin every 3 weekly. So this is the dose and the regime given here. In those who have allergy to penicillin, one can go for use of erythromycin as seen here, but obviously when it is a tablet, it has to be taken every day, and that becomes quite a problem. Whereas if you use injection, then it is just once in every 21 days. And most of the studies have shown that injectable penicillin has much better secondary prophylaxis rates than oral drugs, penicillin or erythromycin. Again, there you will find some people advocating azithromycin 2 times a week or something like that. But actually there is, if you look at the literature, there is absolutely no data on azithromycin or other antibiotics for secondary prophylaxis. How long should we use it? If there was no proven carditis, one can use for 5 years after the last episode or till age 18. If there was mild carditis, one can go on till age 25. However, patients who have moderate to severe carditis, or even those who have had cardiac surgery, the WHO recommends lifelong, but most of us would use it till about 30, 35 years of age, because we know recurrence of rheumatic fever is absolutely or very, very uncommon beyond that age. So we would rather stop it around 30, 35 years of age. So in summary, to prevent and control acute rheumatic fever, you have to identify the local barriers. Many of them are listed here, especially lack of awareness, health-seeking behavior of our community, poor access to healthcare, inability to afford, lack of drugs, lack of interventions. Then prioritize whatever available resources are and the local environment, whether it should be acceptable to the community. What is very, very important is to have supply, uninterrupted supply of penicillin, and community education and awareness, the importance of penicillin. And involve not just the hospitals, but I think the civil society, the NGOs, everybody has to be on board to have a community level supply of penicillin and prevention of rheumatic fever, rheumatic heart disease. So this is probably my last slide, which shows that rheumatic fever, rheumatic heart disease has been declining dramatically in countries like Bangladesh. So we always talk of US and UK, where we know things have improved, the overcrowding has gone away, the access to healthcare is very good. But look at Bangladesh, our neighbor, a country much younger than ours, they've been able to make quite a dent in the incidence of rheumatic fever and prevalence of rheumatic heart disease. And this happened in 1997. And then there was a recent study in 2015, which again said that this trend is continuing and they don't have any resurgence of rheumatic fever, rheumatic heart disease. How has it been possible? Early diagnosis and treatment of strep pharyngitis, aggressive primary, secondary prevention strategy, both primary and secondary, lot of training of health providers, frontline health workers, large-scale education for rheumatic fever, about rheumatic fever, rheumatic heart disease. In fact, they have it in their curriculum, I think in class 6, about what is rheumatic fever and how does one get it. Involvement of the community, including teachers, and of course, active epidemiological surveillance. So coming back to the summary, acute rheumatic fever has been in the past and continues to be a public health problem in many parts of the world, including our own. It primarily affects children and young adults. There is no specific symptom, sign, or a lab test that is diagnostic of ARF. Jones criteria are good guidelines and will be helpful, but should not be substituted in place of clinical judgment, especially in countries where rheumatic fever is endemic. Early diagnosis will reduce the severity of carditis and thereby will help in reducing the severity of chronic rheumatic heart disease. The treatment remains largely symptomatic. Valve replacement should be considered only in fulminant cases, not getting more stabilized by medical therapy. And what is most important is meticulous secondary prevention to prevent further episodes or recurrences of rheumatic fever, because that will reduce the severity of rheumatic heart disease. And what is the future? I hope and pray that with all the effort that's going on in the world all over the world, African countries, Asian countries, we should hopefully be able to eradicate or at least end rheumatic heart disease, because that is definitely a theoretical possibility. Thank you very much for your attention.
Thank you, Professor Anita Saxena, for such an enlightening lecture covering all the aspects of acute rheumatic fever, what everybody of clinicians and all the budding cardiologists and everybody of all us should know, from diagnosis to treatment and prevention. If there are any questions from the audience, and Professor Saxena would be happy to answer.
Oh, thank you, ma'am, for an exceptionally good lecture. We have Dr. Samod Kurian, sir, and Dr. Rakesh Yadav along with us. And also we have the residents, and some of the questions that are coming that I would like to just say is the conditions which are exception to Jones criteria, very commonly asked from the residents.
Yeah. So I think one of them is when we talk about is smoldering carditis or an ongoing carditis, where we used to make that diagnosis quite often earlier, that the patient is not improving, therefore there's an ongoing carditis. I'm not very sure if that really happens. I think it is the cardiac lesions that go on becoming chronic, and therefore we think that it is ongoing carditis, and some of the ASLO and all may stay high. And we know that ASLO takes time to decline. ESR declines earlier, but I think there is still a small subgroup of patients where there is an ongoing carditis, and these may be the patients where when you are tapering the steroids, you might want to add salicylates at that time to prevent a recurrence. So there's a recurrence, there's a relapse of rheumatic fever, and therefore giving, or let's say covering them for a longer period might help us to get these patients out of the smoldering carditis phase into the chronic rheumatic heart disease phase. So that is one. And then of course we have these epistaxis, etc., which I mentioned, which has not been mentioned in Jones criteria, but we have seen a lot of children, and I think it's written in books also, that patients of acute rheumatic fever or suggestive acute rheumatic fever coming with epistaxis could be an indication of ARF. And rheumatic pneumonia, abdominal pain, some non-specific features also.
I remember your seminal article, which was published in Heart in 2011, I think, which on echocardiographic criteria, which helped to diagnose the subclinical carditis. Now, almost all these patients should, who are suspected, should undergo echocardiography, but whether the diagnosis of mild mitral regurgitation or mild tricuspid regurgitation or mild aortic regurgitation should help them to qualify a carditis. What are you have spoken about some nodules on the mitral leaflet and aortic leaflet. Are there, apart from mild diffusion, any other echocardiographic criteria which helps to in these patients, because they have come in now the diagnostic criteria?
Right. So this is the first time that echo has actually been incorporated in the Jones criteria. And in 2002 also there was a lot of discussion about the addition of echo, but generally it was felt that echo is not so widely available, especially in countries which are endemic for rheumatic fever. Now over, I think last 15 years or so, echo has become so commonly available that this time they've actually put echocarditis or echocardiographically detected subclinical carditis as the criteria. So generally one would go for mitral regurgitation, aortic regurgitation as the classical criteria for subclinical carditis. So you don't hear a murmur, but when you do an echo, you find mitral regurgitation and or aortic regurgitation. And the criteria and the Doppler criteria that they have defined to differentiate it from trivial or normal mitral regurgitation has also been published in that article, which I showed. So having a valvular regurgitation in a patient who's clinically appearing to be normal is an indication of carditis in somebody diagnosed as rheumatic fever. The other things like mitral nodules, again, they were described by Dr. Wasson in 1995, quite a long time ago, from when he was at AIMS, and these were found in about 25%. In our own study, we were able to get mitral nodules in the study of rheumatic carditis that we published. They were present in, I think, 27% of all cases. So rheumatic nodules are very, very, I wouldn't say diagnostic, but they are important feature of acute carditis. Small pericardial effusion, flail leaflet, rare, but it's quite diagnostic, and tip prolapse of the anterior mitral leaflet. So these are some of the echo features which would suggest that patient may be active carditis. But again, the diagnosis primarily is made by the major criteria, minor criteria, and lab criteria. So in somebody who is perfectly looking fine, having no fever, no joint pain, no increase in heart rate, you just find a couple of nodules, I wouldn't make the diagnosis of rheumatic carditis in them. But yes, in a clinical setting, these are very important.
Another important thing that you emphasize is that penicillin is the drug, because resistance of streptococcus is not seen to penicillin. So it is a drug still, despite antimicrobial resistance to multiple bacteria, the streptococcus still is sensitive to penicillin and should be used in all these patients suspected to be having acute streptococcal sore throat. Not difficult to distinguish, as you have highlighted in the criteria from coryza or so. I think every patient who is having such symptoms should be given, and then the prevention of spread of pharyngitis from one person to another can be prevented, which is very important, I think, that you have rightly emphasized. And even another thing that you emphasized, that even after viral placement of patient rheumatic heart disease has undergone viral placement, patient should continue on prophylaxis to prevent the development of valvulitis or rheumatic fever in the other valves. So that also should be remembered, that she has highlighted. Any other question?
Some more?
I have a doubt, sir. Hello.
Please, somebody was asking, you know?
Sir, Surya, resident from Madras Medical, Chennai, sir.
Yes, please ask.
Sir, I have a doubt in pathogenesis, sir. In my last exam, it was why the joint pain in rheumatic fever was migratory in nature. Is there any immunological mechanism which leads to this migratory arthritis? Why it is migratory?
So the short answer is I don't know, and I think it's been not written in the literature also why are they migratory. But typically, you don't get that kind of migratory arthritis in any other condition. So they're quite typical for rheumatic fever. But having said that, please don't think if migratory joints are not present, joint pains are not present, then it is not rheumatic fever. Migratory are present in a minority. They're very typical and diagnostic, but they are not present in majority. So therefore, it's not that every patient with rheumatic fever will have migratory arthritis. But yes, it is an ongoing inflammatory process which goes from one joint to the other. But in a number of cases, you will find two joints involved simultaneously. And now they have included even monoarthritis as a major criteria, monoarthralgia as a minor criteria. But the pathogenesis of why some people get migratory arthritis, I don't know. But what I can tell you is that somebody who had migratory arthritis in one episode is likely to get migratory arthritis in the next episode also. So this has something to do with the host and not with the agent or environment. It is called mimicking the features of rheumatic fever. So somebody who has a recurrence of rheumatic fever tends to get exactly the same symptoms that he or she got in the last episode.
How common, what is the latest data? How common is acute rheumatic fever? What is the by data, rheumatic fever and rheumatic heart disease? If somebody is asking in the latest values,
right?
Should we predict?
So I think it has varied in different regions from 10 per 100. When we talk of rheumatic heart fever, we talk of per 100,000 or a lakh population. So unlike rheumatic heart disease, where we talk of 100,000. So here we say it varies from 10 per 100,000 to 300 per 100,000. So I would think, I don't know exact data from India because we haven't published it and I don't know of any published data recently, but I think in India it will be more like 40 to 50 per 100,000 population in the 5 to 15 year age group.
Ma'am, you told that in a patient with activity, one should not do surgery. So is it mandatory that every patient undergoing a mitral valve procedure, either by balloon or with the surgery, should have a routine screening for ASO and CRP is needed, or it's not needed? Clinically is sufficient. So
what we've been doing is that in children, that means under 15 years of age, we are doing it as a routine. Every child who is undergoing a surgery, even if he looks, not active clinically, obviously these patients are symptomatic because of severe valve lesions. Once they're undergoing surgery, they would be likely to be symptomatic. So they would undergo an ASL or CRP ESR as a routine. But in older patients beyond 15 years of age, if patient is not showing any clinical feature of acute carditis, we are not screening them.
And since the graph is going steadily down, is there a real need to pursue after a vaccine, or should we stop pursuing a vaccine?
I think the graph is not really going down in many other countries. In fact, if you look at Africa, and in fact, people even in Western countries are seeing a resurgence of rheumatic fever. You know, even in US also there has been a little increase. So therefore, I don't think it's going down. Maybe it is going down in some countries, but I think the vaccine is still being. I think a lot of research is going on. There are at least 5 vaccines which are undergoing research. Unfortunately, we haven't got any till now, and most of the projects that have happened in the past have failed. But at least 2 of them, I think, in next 10 or 15 years we might get. And this vaccine is for actually streptococcal infection. This is not for rheumatic fever, rheumatic heart disease. It's for streptococcal infection that we're talking about. So having a vaccine is going to help anyway for sore throat.
The group of streptococcus that we have in India is different from the Western population, or is the same?
I think in the ICMR study where they did throat swabs of some lakhs of children from various areas, they found it to be same. Yeah.
As the studies have shown that the oral prophylaxis is almost as good as a placebo, should we still give oral? Because the studies did not show any benefit over placebo.
Yeah, I don't know. I believe that something is better than nothing. So many of these patients find it very difficult to get injection. It's very easy for us to say that take 3 weekly injection, and we try to study this quite carefully in our registry, and we were surprised to see that with a lot of emphasis people were trying to get injection. But the trouble is that they have to go so much of a distance to get an injection. Doing that every 3 weekly from a rural area becomes very difficult. So sometimes those who have milder form of rheumatic heart disease, I settle down for oral prophylaxis if I find that it is very difficult, because the milder form of rheumatic heart disease don't usually progress much, and therefore I think if they can't get an injection and therefore they don't get anything because they're totally asymptomatic, I would say, okay, take erythromycin if you are comfortable. And penicillin has gone out of the market so many times in the past that we always have to give them an alternative. Otherwise, they just stop. I don't know if we should do another study to see if it is as good as placebo. I believe that it will have some protective value. Yes, it will be less than injection for sure. But in milder cases, in cases who are finding it very difficult to get it, it may be okay to allow them to have erythromycin.
Now even penicillin has not been coming for a long time.
Yes.
We are working without that. So probably the only tablet that we are writing is erythromycin.
Yes.
Patients are taking, and for years and years we are writing, but you're right that there's no clear documentation or evidence that they're actually working.
The only trouble is with oral, sometimes patients forget to take, and that is where the the efficiency or the efficacy goes down. That is the problem.
From the exam, many times the residents are asked about the protocols to follow. There's a WHO criteria, the HA criteria, then for the echocardiographic criteria of the valvulitis, like there is a criteria from South, and then there are Jones criteria given in circulation for echo diagnosis, especially for the subclinical, which now is an integral part of the guidelines. So how do we, and what should they be answering? That's a very practical problem they face. Examiners will always like to listen what they like. A balanced answer. That's a very normal thing. So basically, what would be a judicious and a cautious approach for the residents?
I think this 2015 article has really come out, something it's like a boon for residents, and it has so much material in it that if residents read it, carefully, know the difference, what has happened, what are the criteria for subclinical carditis by echocardiography for subclinical carditis and all, I think that should be a sort of a statement that every examiner should accept. I agree with you that some of us want to know what we want to hear. So that is something which is right, but unfortunately the data from India is not so robust. It's there, there are criteria like Vijay Lakshmi's criteria and all that, but I would think if they use 2015 article where they talk about practically all these points that you said, that should be a credible statement from the candidate, and the examiner should accept it.
So, my dear friends, actually, this was a terrific review. Most of the questions that you are typing now have already been answered. If you can just listen to this lecture again, Madam has very nicely elucidated all these points, and many of them are given in the guidelines. So I would suggest that, as Madam has suggested, there are 3 or 4 articles. One of the reviews in Lancet that has come up on acute rheumatic fever that summarizes all the approaches very nicely. Then the article on guidelines 2015 circulation. It summarizes all the echocardiographic criteria and everything very nicely. What is the reason and why we should be doing this? So if you can just read this acute rheumatic fever in more detail, probably it will be a stamp or a icing on what you have listened today. So, ma'am, thank you so much for giving us such a wonderful and a fantastic lecture. My dear friends, this particular lecture will be available on the YouTube channel day after tomorrow, and you can easily listen to it for those who have missed. Although, ma'am, we have 436 residents at present who are online. So that's a huge number as far as this are probably the highest that we have had recently. So they have really enjoyed this talk. We are getting numerous comments also. And in case you have any further questions and comments, we would be very, very happy to answer all the questions. Please write to us on PGTrack Delhi branch at gmail.com. You have any particular questions, comments, or clarifications or particular sessions that you want. I have been getting these requests. We will love to incorporate and call our most respected speakers for your benefit. Again, I remind you to join us on our weekend conference of cardiology, Society of India Delhi branch. It would be a great event. And on the behalf of the Cardiological Society of India Delhi branch, thank you so much. It's been a year on this wonderful journey. Thank you so much, ma'am, for guiding us through this wonderful topic in such a easy and a lucid way. I also thank respected Dr. Tyagi sir, respected Dr. Rakesh Yadav, respected Dr. Sumod Kurian, and all the fellows. Because of you, we are here, and I hope you enjoyed this particular session. So stay safe, enjoy, read, and nourish your knowledge. And we'll come up after a gap of 1 week. Next week, we won't be having any webinar with another new, different avatar of CSI Delhi branch PG track program. Till then, have a great weekend. See you on the weekend and catch up with a new session, new series. Once again, have a great day. Thank you so much, ma'am. Thank you.
Thank you very much.
Thank you.
so much.
Thank you.
Thank you, Intas, for providing us this platform.
Thank you.